Remembering how to evaluate the risk can be very difficult. Hi, I'm Gleason, head athletic trainer at Purvis High School and DAT student at Indiana State University. Welcome to video 2 of the two-part series where we try to sharpen our skills on risk evaluation. So come along with me as I try to give you a hand on risk. In today's video, we're going to talk about SLAC wrist. Scaphoid lunate advanced collapse. The patient comes in with that all too common Fuchs injury. We palpate over that anatomical snuff box, and we have nothing. We flip to the palmar side, and there's a little bit of motion in that scaphoid. These often go undiagnosed. The Watson test can help us narrow this decision. It has a positive likelihood ratio of 2.76 and a negative likelihood ratio of 0.25. Now, although that's not the strongest, it does help us narrow the field. Most agree that putting them in a brace for about 2 weeks and then reevaluating to see if their symptoms improve. Now let's take a look at that Watson test. Now that we've reviewed some of the anatomy of the carpals, and we're reminded of that steamy acronym that we learned in our undergrad anatomy class, let's take a look at some of the dynamic motions of the carpals specific to the scaphoid in relation to the wrist. When the wrist is in a neutral position, the scaphoid sits at about a 47-degree angle in relation to the radius. As we move into ulnar deviation, the scaphoid long axis aligns with the radius. As we move into radial deviation, the scaphoid, since it sits on the first row of carpal bones, has to move out of the way to allow that action, or it flexes. And that is the key to this test. What test, you ask? The Watson test, or the scaphoid shift test. There's multiple versions of it, and I'm going to show you those so that you can use different patients or different hands. So, as we get the patient into a comfortable position, placing a towel in place, we're going to get them into ulnar deviation with slight extension. As they're in this position, using my hand around the back side of the radius, I'm going to brace against the radius and with my thumb apply an AP pressure to the scaphoid. As I'm applying pressure to the scaphoid, simultaneously I'm going to move the wrist into radial deviation with slight flexion with the other hand. This passive motion should produce a clunk or a painful response for the patient if it's positive. In this case, normal motion from the scaphoid pushes my thumb out of the way as it flexes. If we get a positive sign from this, this is a positive for a scaphoid lunate ligament rupture or sprain. Another version of this is to wrap the hand from this side using the fingers to press on the scaphoid. Same action, pressing AP pressure on the scaphoid as moving through radial deviation and slight flexion, looking for that clunk or shift. Another version some clinicians use is to apply a drawer type pressure on the scaphoid in this manner as moving through the range of motion. Press, 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 looking for that clunk or that painful response from the patient.